Good evening. My name is Dr. Sarah Cole, orthopaedic surgeon based in Cairns in far north Queensland. And tonight I'm very excited to talk about something that is above the orthopaedic line, concussion with Alyza Brown, because I think it's really playing out as a big live issue, certainly for us orthopaedic surgeons in all our contact sports. I'd love to hear more about it.
Yep.
Thank you.
Absolutely. Okay, so most of you are my colleagues, which is great, but my name's Alyza, and I am a physiotherapist at Embodied. I graduated in 2019 and did my concussion training towards the end of 2020, and have since been working pretty consistently within that field, both in the sporting realm as well as in third-party compensable schemes such as your work covers, your CTPs, etc., etc. So with concussion, it's had a major sort of outreach recently, especially in the media and in the literature, because everyone wants to know how do we reduce the amount of concussions that are being sustained in sport. But it's not only sport that we are seeing a lot of concussions. Primarily at the clinic, we actually see private patients and third-party compensable patients as well. So I have a history myself of playing contact sport, including rugby union, and I witnessed firsthand a lot of the attitudes that a lot of community level athletes have towards concussion, and I can pretty well say it's pretty below average level of knowledge. And that's where the awareness building and our role as health professionals comes into play in terms of being education members, but also people who can help break the stigma of actually reporting concussions and whatnot. So I know we've got a few physios and exercise physiology as well. Yep, okay, awesome. So everyone has a role to play. Concussion management is multidisciplinary. We involve OTs, we involve exercise physiologists, we involve sometimes dietitians if it's warranted, and also obviously physiotherapists for rehabilitation. So we'll go into a little bit more of that. But it's super important that everyone is on the same page when we are dealing with these injuries, so that we can all kind of come at it from a really good point of view. So that leads me into this. So why have a concussion clinic? So there's been a rapid increase of publications on concussion in recent literature. Unclear behind the reasoning. It could be higher incidence of reporting. That's what we're more so thinking. Also likely to be an increased awareness of what a concussion is and what to look out for. Unfortunately, it's very likely that community sports are actually underreporting their concussion rates, and that's probably due to lack of awareness, as well as patient reporting as well. So I tend to find that people will deny often having concussion or not really know what it is. So it's important that we're able to educate on what to look for and why it's important. According to the Australian Sports Commission, underreporting of concussions and failing to seek medical advice range from 17 to 82%. So that's a massive deficit. We don't know the specific numbers, so it's quite scary to think about how many are kind of sliding under the radar. The fact that large numbers of concussions are going undetected and therefore unmanaged obviously is quite concerning, and the reason a lot of players have indicated that they decline to report concussions are primarily due to not wanting to be ruled out of the game or training session, which accounted for about 58% in some studies, or not wanting to let down the coaches and the teammates. These results are consistent with other survey data, and it kind of just speaks to the knowledge and attitudes that are still existing in community level sports primarily, but also still up further in the chain. It's important also to talk about the patients who sustained concussion through workplace injury or motor vehicle accidents or other means, and this is an area that I find is underreported on because we tend to only focus on athletes and how we're going to prevent concussion in sports. But the bulk of clientele, like I said, that we actually see in clinic is formed up of normal people who become injured within the course of their day, either on their way to work, in the car, or they might have had an injury at work, or they might have had a fall at home, or something like that. So really important to kind of be aware of the fact that it is prevalent everywhere, essentially. So what you might not see after a concussion, people will often, if they don't know what to expect, they will often go to work. They look normal. They laugh, they smile, they're talking to their friends, they're engaging, but they might seem a little bit more reserved. They might seem a little bit more quiet. They often describe feeling like quite foggy, but a lot of this can sometimes go in the background. They might just fob it off as something that they normally experience. So symptoms that you might be looking for might include pounding headaches, nausea, blurry vision, a range of mental health symptoms as well, such as anxiety, depression, cognitive fatigue, sensitivity to bright lights and loud noises, memory loss, difficulty processing information, sleep issues, which could be excessive sleep or sleep disturbances, dizziness, and sometimes behavioural changes. So what is a concussion? Has anyone actually worked in concussion space before? Ever seen a concussion patient? Have you? And so?
I've been in sports as well, but
yeah,
I'm interested on the thing that I work at the club when I was just coming out of uni, so I wasn't really sure on how to treat it and how to go through it.
Yep. So first of all, it's important that we educate people on what it actually is. So a concussion is a mild traumatic brain injury, and it can be caused by a direct blow. It doesn't have to be necessarily a direct blow. We've had some patients who've come from sustained exposure to vibratory forces through work cover. But it usually is sustained by a direct blow, usually to the head, face, and or neck, but it can be anywhere else on the body. It just has to be enough to submit or transmit force through the brain. And it's kind of an impulsive force that causes a bit of a shearing effect, a stretching effect within the brain, which causes the release of a whole bunch of excitatory neurotransmitters and sets off a whole range of action potentials. It doesn't always involve a loss of consciousness, so that's something that was thought to be a clear sign of a concussion, and it is. Like, if they have a loss of consciousness, you can pretty well say definitively that's a concussion, see you later. But it doesn't always have loss of consciousness. In fact, more often than not, it probably doesn't. And it may not always be present with immediate symptoms. That's something else to monitor for. Sometimes symptoms may be prolonged as well, and that is then labelled as something called post-concussion syndrome. So the neurometabolic cascade of concussion, so into a little bit of neuroscience. Basically what happens is the impact and concurrent force that's transmitted through the brain causes a stretch within the axons, opening up the channels within to allow an exchange of ions. Usually this would generate an action potential, so something would usually be present to trigger it. In this case, there's not. So essentially what happens is there's a whole influx of an outflux of chemicals within the axon. So you have calcium coming in, potassium rushing out, causes a massive release of glutamate, sets off all these other axons within the brain, and all of a sudden you have this massive excitatory response within the nervous system tissue. Essentially what happens is there's a metabolic crisis, and we have to release a whole bunch of ATP, our energy molecule, to try and bring that back down. So what that looks like over time, when they studied ATP levels after a moderate traumatic brain injury or a mild traumatic brain injury, which is what a concussion is, we tend to see that there is a rapid drop of ATP levels within the bloodstream within the first few hours. Then human studies show that they start to climb, and some studies show that it takes up to 4 weeks or 30 days for those levels to return to normal, and that is really, really important. There is difference in opinion in literature, which is probably where a lot of the different return to play rules come in for all of your sporting codes. But some studies say it can take up to 30 days as long as you have normal recovery timeline. And that becomes really, really important when we're making a decision for someone as to whether they're going to be ready to return to play. So, what happens if you return to sport too soon, or if you sustain a concussion again? There is a phenomenon called the second impact syndrome, which can cause death, where they might not have been returned to, pulled off the field early enough, and they sustain a second concussion within a matter of hours or minutes even. For example, there was that Tongan NRL player recently who has had to have surgery because he ended up with a massive brain bleed because he sustained a head knock in training, was cleared to play, sustained a head knock in the first half of the game, and then sustained a third, and then was very, very, very unwell and taken to hospital. That's in very serious cases, but it's very important for us, especially for working at community levels, to be able to recognise the signs to prevent any permanent damage from happening. But if we think it's taking about 4 weeks for these ATP levels to rise again within the brain, and we're sending someone back to sport, say at 7 to 10 days post-injury because they're feeling better and all their symptoms have resolved, their ATP levels might not be at 100%. They sustain another concussion and all of a sudden the process happens again, usually worse. So we usually see a larger deficit in ATP levels and worsening symptoms. Eventually it gets to the point where you see permanent changes within the brain as a result of cell death. It also then takes longer for those ATP levels again to recover. And again, if you have another knock, etc., etc. So very important that we respect a really healthy return to play timeline. Thankfully, the AIS have released some guidelines recently as well, which I will talk about, but they recommend a minimum 21-day stand-down period and 2 weeks symptom-free. So if you get to 21 days and you still have symptoms, you have to wait 2 weeks until you're symptom-free at least, and it has to be 2 weeks of being symptom-free. That's their recommendation across the whole sporting code. I think that rugby union have yet to adapt that. I think AFL are coming close to adapting those changes. But yeah, a lot of sporting codes have their own kind of guidelines as to what to expect. Okay, so what might you see within a concussion? So we talked about dizziness, headaches, blurred vision. They might have forms of vertigo. They might have nausea. They might have neck pain. They might have difficulty remembering phone numbers or names. That's usually something that I will see. They might have gut health problems. They might have balance issues. There's a whole plethora of symptoms that might be present, and it's tricky because the brain obviously controls everything. So it's not really limited to any one thing, which becomes a bit difficult when we're dealing especially with third-party compensable schemes who are saying, well, their headache's better, why aren't they back yet? So the infographic basically shows a few of those symptoms that might be experienced by patients. It's really important to note that because of the existence of the gut-brain axis, gut health inflammation plays a key role in sort of recovery from a concussion, which is why a whole person approach is really, really essential to treating patients who have sustained a concussion. In recent years, there has been research conducted that examines changes in cerebral blood flow following a traumatic brain injury, and they are looking at the pathophysiological aspect of a mild traumatic brain injury as well. And what's been found is that sometimes there is a decreased blood flow within the brain immediately after a concussion. Some studies show that this blood flow impairment can last up to 30 days, which again links in with our return of our energy levels, even in individuals who are no longer exhibiting symptoms. And this is thought potentially to be due to autonomic nervous system dysfunction. So usually a heightened fight or flight response is the culprit. So we'll talk a little bit more about that, but that leads to obviously blood vessel changes, dilation, constriction, sustained abnormal blood flow patterns, etc. So what does this mean for our decision making? Rule of thumb, if you're unsure, just if in doubt, sit them out. That's the biggest thing. And that's inclusive of returning to work or returning to school. I always remind my patients that they only ever get one brain, and it's important to look after it because there's no repeats or redo overs or replacement surgeries or anything like that. Like, this is it. Again, different sporting codes have their own guidelines on the time taken, but it's important to consider the research. So even though if they play rugby union and their stand down period, I think it's 21 days for kids, and I think for adults it might be 18 from memory. I'd have to go back and double check that. But it does differ. So you might see someone who's like, well, it's been 2 weeks since I've had my blue card and rugby says I can go back. It's not quite the case. So very important that we're driving the rehabilitation and the clearance, and also communicating with the rest of the medical team and the coaching team or the workplace or wherever they're trying to return to. Very relevant for us with community level athletes because we just don't have the resources available of a whole sporting medical team or anything like that as well. And we may be the only line of defence that stands between them and getting back on the field. So really, really important. So if in doubt, sit them out. And familiarise yourself with the Australian Sports Commission AAS concussion statement. Really awesome that we actually have one. It's only a new thing in the last couple of years, obviously 2024. But there's also international consensus statements that are released, I think it's every 4 to 5 years. So keep an eye out for those. Make sure you're familiarising yourself with the guidelines. So recovery and prognosis from a concussion. I tend to find in clinic, this is a little bit anecdotal, but I tend to find that those who've sustained a concussion in traumatic instances outside of a sporting environment, so for example, at work or in a motor vehicle accident or a fall from home, they tend to take longer to recover for whatever reason. And they usually present with more complex symptoms. Would you agree, Mikey?
I think it's just the fact that athletes want to get back quickly.
Yeah.
And then I don't know if they're under the third-party compensation schemes. There's yellow flags and
lots of extra things that are impacting their recovery
and stuff like that.
Yeah,
but athletes probably their health is already better when they sustain a concussion, and then they're really eager to get back to field.
Yeah, absolutely. So again, that's not necessarily something that's backed by research, but just keep it in the back of your mind that that can happen. Other factors likely to impact prognosis, concussion history and their recovery from that. So if you're working at a community level, oftentimes athletes will have had multiple concussions within their life. If they have had multiple concussions, usually the severity each time is worse and it takes less of an impact to generate those symptoms. So if they have a concussion history and whether or not they are rehabilitated does impact how their recovery is going to go this time around. If they have a higher symptom severity score, so we use the post-concussion symptom severity score, there's also the Rivermead post-concussion severity score, which is another good outcome measure, but a higher score is a longer recovery, which is usually the same for most things. Pre-existing depression and anxiety or any other neurodivergent diagnoses such as ADHD or autism also can impact the longevity of symptoms experienced. Lack of education about correct management, history of insomnia or sleep, history of poor gut health, all of those things kind of create a person who might be more prone to experiencing symptoms, which means that their symptom severity score will be higher experience. Being female also associated with high symptom severity scores and having a longer recovery, and that's the same across all age groups. And again, that could just be, it might be that maybe women feel a bit more anxious or they're a bit more health conscious about their symptoms, whereas males, especially in community sports, might just be wanting to brush it off and be kind of tough and just return to sport and get over it. And then as we get older, also impact of hormones and everything also impacts how quickly you can recover. 30% of patients will go to post-concussion syndrome without early intervention. So the earlier you can get in and start rehabbing someone, the better they're going to do. It's the same as any kind of injury. The sooner you start rehab, the sooner you get better. So our approach to treatment at Wellness Embodied. So we have a multidisciplinary team and we have 4 concussion trained staff members now, and we're looking at getting more OTs trained up as well. And that is so we can attack the rehabilitation from all facets and make sure that we are delivering a whole person-centered approach. Management of both acute concussion and PCS is holistic, and it will centre around a whole variety of different pillars of medicine, including diet, physical exercise, sleep management, stress management, and avoidance of risky substances and positive social connections and interactions, as well as physiotherapy rehabilitation for, say, neck pain or headaches or balance or whatever it is that they're presenting with. So, We follow a little bit of a template. So we completed our training through Complete Concussions. There is now training available within Australia by Australian companies, which is awesome to see. But essentially it follows a nice step-by-step approach. So basically what we'll do on the first visit is take a full comprehensive history, which includes a questionnaire called the SCAT-6, which is the Sporting Concussion Assessment Tool. That's within 72 hours, so you can use that on field or 72 hours post. Because research shows that it actually normalises 72 hours. If it's after that time frame, you can use the SCAT-6, which is an office assessment tool. And that's for anyone who's sustained a concussion and you're seeing them longer than 72 hours post-injury. That's really freely available online. Like you can Google the SCAT-6 and it'll come up with a PDF that you can just print out, and it's really easy to use. So if you're working in sports, I definitely recommend having that available on the sideline so that you can quickly go through whatever you need to. Patient education and reassurance is also really important. We also rule out in our first visit, obviously, need for further referral. So we're looking for any kind of damage to cranial nerves. We might be checking for any missed brain injury that needs urgent referral, neck fractures, like the really nasty stuff that might have been missed. A lot of the time they're coming to us 4 or 5 weeks down the track. So with imaging intact, if they've had a severe one, so usually we can be quite reassured, but we still do due diligence and make sure nothing's being impacted from that point of view. For acute concussions, then we look at the Buffalo Concussion Treadmill Test. There is different types of testing criteria for young athletes as well as older individuals. So you've got the March test for older people or people who don't exercise. And then you've also got your pediatric concussion treadmill tests for 5 to 12 years old. And there's also a bike option available. So for example, if you have someone who can't get on the treadmill and walk or doesn't feel safe on the treadmill, there is a bike option as well. We usually try and do that for our acute concussions within the first week, and that's to determine if an increased demand for oxygen and blood flow to the brain produces their symptoms. That tells us if going back to sport or exercise is going to make them worse. If it does, we'll go through exactly what we do with treatment, but we do have a sub-threshold exercise plan that we will give based on this. And this is where exercise physiology comes into handy to run these tests and give targeted exercise to help with heart rate variation, etc., etc. We will also book in for a cervical and vestibular assessment if warranted. So some people, if they're coming in with dizziness, we definitely get them in to see our vestibular physios pretty well straight away, because that's really important to get those symptoms down as soon as possible. And then we're also assessing and treating their neck. The reason for that is because we tend to see, it requires more force to sustain a concussion than it does a whiplash. So usually if someone's coming with a concussion, they will have a whiplash component. It's really important to assess and treat the neck to determine if that's contributing to symptoms or not. Here is kind of it's like a rundown of what you would see in like a handout for patients for what to expect in terms of their recovery. Lots of sporting codes have their own variations. So essentially what we advise within the first 24 to 48 hours is symptom-limited activity and light cognitive activity. That means if they are supposed to go to work, they injure themselves on the Sunday and they want to go to work on Monday, probably a good idea to have a couple of days off just to allow their brains to calm down. Because if you go in and start challenging the brain when it's in an inflamed state, it's probably going to inhibit their recovery. Symptom-limited activity. It used to be that it was go and sit in a dark room and don't do nothing, basically. Don't go to sleep, stay awake, but in a dark room. What we're finding is that increases people's sensitivity to symptoms, especially things like lights and noises, and it doesn't really help their recovery. So what we're recommending is symptom-limited activities. So if they're doing something and it's worsening how they're feeling, then they need to slow down and have a bit of a rest. Then we look at gradually returning people to work and to school. And that can be over however long you need. So essentially, we would usually start with like, okay, let's go to a half day of school or a half day of work, and if they're symptom free for that whole day, the next day they can go a bit longer. Same thing, the next day they go a bit longer. If they're getting symptoms, you can kind of pull them back a little bit and do less, and gradually rebuild once they're feeling symptom free. It's a very touch and go situation, and it's not always clear cut. Some people might go to school that second or third day and be fine. Some people will make it to recess and be absolutely flattened for the day. So it's just a case by case, and there's no sort of set timeline on how long it can take to get someone back. We also follow through different clearance testings to get back into light sport or exercise, which is the Buffalo test, but then we also do a higher intensity test if they've passed the Buffalo and they need to get back to contact sports, and that's called the Black Hawk Chicago concussion test. And that's also available online, and that's a really high intensity test designed to stimulate high heart rate, but also involves lots of different chopping and changing of directions, jumping, twisting, etc., to also challenge the vestibular system and simulate a gaming environment. So prolonged concussion. What causes prolonged symptoms? So there's 5 main causes of why someone is getting symptoms. The first one we touched on, which is the reduced blood flow to the brain. The second one is the metabolic inflammatory changes that were unresolved, and that's to do with the gut-brain axis. Visual or vestibular impairment, cervical impairment, which is the whiplash component, and then also psychological stresses. So really, really important that you're ticking off all of those boxes when you're assessing to make sure that you're addressing every single aspect of a concussion that is available to you. The definition of PCS in our training was symptoms lasting longer than 10 days, but it does vary. Sometimes it's 14 days, for children it's 30. But if it's been sort of more than 10 to 12, we tend to do a post-concussion assessment as opposed to an acute concussion and use different tools and whatnot. But the sort of assessment of it still stays the same, which is really, really nice. So you don't have to worry too much about what you're doing as long as you're ticking everything off. So same sort of flow chart, we do the history taking, very heavy focus on reassurance in that first session if someone has had symptoms that are lingering for a long time. Really, really heavy on that education and reassurance. We still do the treadmill test, and we still go through and do our cervical and vestibular visual test. What we tend to see is that addressing sleep, diet, and mental health are major components in our post-concussion patients, like our prolonged concussion symptoms patients, as opposed to acute concussions, where it tends to be more like rehab and exercise-driven. Education is key in these prolonged symptom patients. So almost all patients presenting with post-concussion syndrome will have a psychological component that is impacting their symptoms. Something called the good old days bias, which is like, I always used to be able to remember such and such's name or such and such's mobile number or how to get or this address or something like that. Reality, they probably didn't. They just thought they did. But also there is a lot of phenomenon saying that when you have sustained concussion symptoms, it kind of puts you into a place where it's really hard to concentrate. You're almost on autopilot and your executive functioning is limited, and that's where that memory change is coming in. It's just the fact that you're not present all the time because your brain is just kind of sitting back and switching off. And that's where the poor memory, difficulties concentrating, good old days bias is coming in. We also see with post-concussion syndrome patients that they will have a high level of anxiety associated with their injury. And this is a bit of a diagram on the gut-brain axis. So what we've sort of found, or what some studies have found within concussion recovery and within testing, that's also something important to note, is that there's no actual gold standard test for a concussion out there. There's no scan or anything like that. But in blood tests, what they found, because of the inflammation throughout the whole body, what happens is that the blood-brain barrier sort of expands, and we get the sort of chemicals that are usually found within the brain leaking out into the gut, inflaming the gut, and then vice versa. Chemicals that are found usually within the gut come up into the brain, and they perpetuate this cycle of inflammation, which is really, really important to be aware of, especially if your patient has a history of gut health issues. That's where diet comes in. So that's just a bit of an infographic showing exactly how the brain impacts the gut impacts the brain, vice versa. So, rehabilitation. Subthreshold exercise, that's usually determined by results from the treadmill test that we complete. We also complete neck and upper body rehabilitation depending on what the patient needs. So usual just cycle rehabilitation, we'll do manual therapy, we'll do targeted hands-on treatment for headaches. We will do any kind of strengthening exercises that the person might need to help their neck improve, and upper body rehabilitation as well. We will also complete rehabilitation that is designed to get someone back to optimal function, whether that's for a sporting field or work. So we do things around like their balance and proprioception, reaction times, dual task performance, a whole plethora of exercises. Like, your imagination is basically your limit into what you can do, but it's really important that you're considering what your patient does in the rehab that you're prescribing them. For example, if I had someone who only walked for exercise, I probably wouldn't get them doing lots of jumping and twisting and turning exercises for their balance and stability, because they just don't expose themselves to that load, especially when they're in their 60s. Vestibular and visual rehabilitation. So we're lucky to have Mikey with us at our clinic, who is a vestibular physiotherapist and is fantastic, as well as Clara. And they take that side of things, so they're looking at the inner ear system, determining where dizziness or balance issues might be stemming from, and then prescribing specific exercises based on that. With diet, we did have a naturopath on hand, but she's since retired, so we have a sort of information handout that we give people on how to sort of manage their diet, foods to avoid, such as processed foods, and eating only organic, avoiding as much gluten as possible, avoiding like sugary foods, alcohol, coffee, tea, lots of those kinds of things, as well as different types of foods that can help with brain recovery. And that's all freely available on our website as well. So we use that often for our patients as a resource. And then psychological support as the need is identified. Within the SCIAT 6, you can, and the PCSS actually, there's a lot of questions about sort of mental health related symptoms such as anxiety and depression. There's an anxiety screening score, a depression screening score, and sleep score as well in the SCIAT 6. You can use those to determine if someone is going to need psychological input, and if they are, it's really important that you get them into that as soon as possible. And then also graded return to learn, work and sport. Other rehab options include mindfulness, heart rate variability training, especially if they are struggling with sort of getting back into exercise, using breath and yoga. Yoga and mindfulness have excellent backing in terms of concussion rehabilitation because it helps relax our nervous systems. So really, really important. For kids, so kids aged 5 to 12, if they're older than 12, you can usually treat them alongside the adult rehabilitation, but it's usually much the same. It just becomes a little bit more heavy on education and cognitive support. So that's where you might want to involve OT, where they can help with memory retraining and cognition and returning to learning, etc., etc. So that's really, really important for young kids to be aware of. And then again, other rehab options, mindfulness and yoga. So a lot of the same kind of treatment regardless of how old someone is or how long they've had symptoms for. And finally, the thing that everyone talks about when they're talking about concussion, chronic traumatic encephalopathy or CTE. This has been something that's been in the media a lot recently, especially with athletes who have died and are being examined post-mortem. What we've seen recently, especially in Australia, is that there's a lot of death by suicide from male athletes, even female athletes on occasion as well. And they're looking, once they do the post-mortem examination, they're finding that these people have CTE, which is a progressive neurodegenerative disease, which can be caused by repeated head impacts. These can be concussive or subconcussive. So it's not just the ones that result in a direct concussion. This is really important to consider in contact sport, especially sports such as rugby union, where within a ruck, there is so many points of head contact that might not necessarily be leading to a diagnosed concussion. Like I said, it can only be diagnosed post-mortem through brain tissue analysis, and what they find is there's deposits of tau protein. And it's particularly found in areas involving cognition, mood regulation, and motor function, so such as the motor cortex, the hippocampus, and the temporal lobes. And it's often also found around blood vessels, which is a differentiating feature to Alzheimer's. So that's something that is becoming more increasingly found in analysis of brain tissue in athletes who have died, as well as those with extensive military service. That's what we're seeing in the literature. And more and more people are donating their brains to research for this so that we can understand how better to treat it. But symptoms that might be seen in CTE include memory loss, confusion, poor impulse control, aggression, depression, and dementia. And it's happening in people who are in their 40s and 50s. These symptoms are coming to light. So they might be getting early onset dementia, or they might have outbursts of aggression that are unexplained. They might have substance use issues, things like that, which people would have used to attribute to they've just stopped playing sport and they're depressed. But now what we're seeing is actually there might be some physical changes going on within the brain. Unfortunately, there is no way that we can actually definitively diagnose it before death. So it can only ever be a suspected thing. And a lot of the symptoms cross over with things like Alzheimer's or Parkinson's sometimes as well. So it can be misdiagnosed and it's not found until after the patient has passed away, which is a really, really tricky thing. And this is what I always speak about when I'm talking to community level athletes about concussion, because it's so, so, so important that we are making sure that they're looking after their brain, because in 20 or 30 years, it could be them that we're hearing about in the news with CTE. So really, really sad outcomes, but it's also stimulating a lot more research into concussions and the impact it has long term on our brains. Imaging and other diagnostic tests. As I mentioned earlier, there is actually no gold standard image yet that is available to diagnose a concussion. They're looking at functional MRIs. They're also looking at like Doppler ultrasounds and things like that to look at blood flow, but there's just not enough yet out there that we could then send someone to your local ED for an image and say, do you have a concussion or not? The sports concussion assessment tool normalizes within 3 to 5 days post-injury, so it's not a good return to play test. But you can use a SCITE-6 beyond that for assessment. Limitations to biomarkers. This essentially means that when we're doing blood tests and whatnot, there is crossover in biomarkers that are found within the blood with concussion that are also found with Parkinson's or Alzheimer's or things like that. That's why there's no definitive biomarker that we can use in a blood test. fMRI, again, not enough evidence just yet monitoring patients to full recovery, but it is emerging. Cerebral blood flow, again, mounting evidence suggests that this is altered, but again, they're unsure specifically. But watch this space. I think in the next couple of years, we're going to see more emerging research about different imaging modalities that might help us diagnose. But the best offense is a good defense. All athletes should undergo some sort of a baseline test at the start of the season, so you can then get their results after a concussion to determine if they are ready to return to play or not. Again, that includes things like reaction time testing, the symptom severity questionnaires, anxiety and sleep questionnaires are also important to take as a baseline. A good history of concussion history, and then a whole bunch of like memory testing is available as well for baseline testing. So essentially, if you are being more cautious, you are looking after your patient, which is the most important thing. And if you suspect they have a concussion and you are on the field with them, take them off. You are the medical professional. You are the word of authority. Don't worry about what the coach is saying. Our duty is to protect our athletes at the community level so that they can have good longevity of life. A couple of resources available there. Did anyone have any questions at all about concussion?
Is it getting quite normal that like athletes are getting the baseline assessment?
Not at community level. Overseas, I have friends from America who played sports at school and they all underwent baseline testing at school. And that's very normal practice in some areas in America and in Canada, especially within ice hockey. I think there's massive research coming in that field. But yeah, in Australia, I think you wouldn't find baseline testing until you were getting up into higher levels of athleticism, essentially. Yeah. We have done baseline testing for one women's team. And I think like hearing about the amount of concussion history that they've had was just
pretty much everyone bar one girl who only started playing 6 months before had concussion symptoms.
Yeah.
And the problem is a lot of the symptoms overlap with other things. So they'll say, oh, I'm weak or I'm dizzy or I'm this or I'm that. Oh, but I'm low in iron.
Yeah.
So you're
I've always
like,
yeah.
But when you put all the pieces together, you're like, do you have some residual stuff?
Yeah. The other thing that you'll be fighting against is athletes don't want to be told that they can't return to play. So I had one athlete who played multiple, that's the other thing, at community level, they often play multiple sports. Sometimes they'll play league and union on a Saturday and then go play AFL the next day. And they might have sustained a concussion in league, usually go out that night and then play AFL the next day. And it just makes treating so much more complex because you are just fighting uphill battle. But yeah. Any other questions at all about concussion?
I'm just interested in the self-reporting. So you said that 58% decide not to report a concussion. And some of these symptoms are foggy and cognitive fatigue and not being able to process information. And I just wonder if they're going to start gaming the baseline tests, or do they sort of game the post-injury tests? Like how do you make it objective instead of subjective?
There are testing such as your reaction time, but also a lot of the cognition tests that are available through baseline testing are designed so that they can't fob it. So there is a built-in defense mechanism with some of the available baseline tests. I think the impact test was the old one that we used. There's some other ones online that the software it's designed to, you can't fob it. It accounts
it's still
for
the data on the complete concussion
Yeah,
that anyone can download and do for free. So that was developed for defence forces. And so it's developed to, like Alyza was saying, to identify patterns. If people are answering in a funny way, it will tell.
Yeah, it picks up whether they've fobbed it, and it won't let them proceed, I'm pretty sure. So there are, like, with their symptom severity score, they might try and like fob that kind of thing, but their actual reaction time, their cognition test, they can't fob that. Yeah.
And the thing with the complete concussions is it's a whole battery of testing. So there's a lot of like fancy things that come out where they're like, oh, we've got this $20,000 machine and we go into private schools and we test X, Y, and Z. But they tend to just focus on like the balance and vestibular system. Like they're not looking at the strength, the cognition, the whole picture. So they're good because they're getting objective data, but they're not getting the whole sort of baseline thing.
I think we see a lot of that as well because we see a lot of post-concussion syndrome patients. So our management tends to be very broad as opposed to seeing acute concussion where usually their symptom severity scores are lower if it's like in those first few days and it's sustained in the sporting field and they've not had a major history of concussion before. Yeah.
What are the gut symptoms that they get? Is it a malabsorption problem?
It can be malabsorption, it can just be general like IBS. It could be just baseline nausea, leaky gut syndrome. It can be a whole bunch of different things. Yeah.
And how much vibration is too much? You know, when you said sustained exposure to vibration, how much vibration is too much vibration?
I don't think they
Is this
really
like
know.
Tense,
over time.
or is it like just driving on the mindset?
Well, the person that we had that sustained exposure was driving on a mine site over time in a big sort of piece of machinery and hitting like very bumpy surfaces. And had this constant, I think it was like background headache. It's been a while since we had this patient in, but yeah, there's not a lot of research into exactly the amount of exposure to forces. But for example, a whiplash only requires a small amount of force more than a sneeze. But a concussion is like 10 times the amount required for a whiplash. So that can kind of give you a bit of an idea. Yeah.
Degree of force. It's not inconsequential.
There seems to be a massive deficit between like first aid training and would I say general professions separate to like sporting, because I've noticed in like all of the first aid courses and stuff that I've done, they've barely mentioned it, or if they have, they've been like the black room, don't sleep, and that's it.
Yeah.
But like living and working at sea, we did extensive rescue training, but it was never addressed for head injuries.
Yeah.
It was more like big lacerations or other things, and it's just been like a...
Yeah, I probably found the same. On the sporting field, a lot of people, well not a lot of people, some people will have their sports trainers qualification and they do go into a little bit more concussion depth then. And then the higher up level you go into that, the more exposure they give you. But yeah, a lot of the time, like you're just seeing community volunteers on the pitch who have basic first aid, and they don't really know how to first aid for concussion. But the good thing now is that most sporting codes have like a clear guideline of how to return to sport safely, how to get back into learning and education. Like they have nice, easy templates to follow, and how to educate on like getting assessed and whatnot. But yeah, the deficit is massive. Yeah, huge. Yeah. Yeah.
It's interesting, you're sort of describing how the information kind of trickles out into all the
Yeah.
community systems, and it,
Yeah.
it can start here, but
Yeah.
infiltrating.
incredibly hard to regulate, like...
Yeah.
To get broad enough to
Yeah.
get that information.
Yeah, yeah. So that's usually autonomic nervous system dysregulation. So that's where your sort of mindfulness, yoga, that becomes a really big important part of treatment. It's usually the area that I get the most pushback against, funnily enough. Most people don't want to do, they hate the word mindfulness and they hate the word yoga, and I don't like that kind of thing. So sometimes I just go for a walk in sun. Just go for a walk.
Active mindfulness.
Yeah, yeah, exactly. Yeah.
Is that because that's a certain cohort that you're looking after that don't do that?
Yeah, it really depends. I think,
culture and...
yeah, males, I don't like yoga. I don't like mindfulness.
They're doing Pilates though.
I know.
Men are getting
Everyone's
into
doing
Pilates.
Pilates.
Yeah.
Everyone's
They
doing Pilates. There's Pilates on every corner.
Can't believe it. Yeah.
Yeah.
The number of people that are quietly getting into their Pilates.
Yeah, no, it's really good fit.
Women recover slower because, did you sort of imply that was hormonal? Or?
It's a range of different things. They don't quite know because, like everything else, there's like research around it. But you know, postmenopausal women, increased inflammation because of changes in hormones, so that's a driver for more concussion symptoms. Younger girls, compared to their same age male counterparts in schools, tend to have higher levels of anxiety and uncertainty, and may already have pre-existing things going on in the background. So they'll be, or they might be more high performing they just need a little bit more reassurance and whatnot. So they might be experiencing more symptoms based on that, or they might just be reporting higher symptoms as well than boys who are just like, no, it's like a 1 out of 10 headache. It's very variable. They don't really know. There's too many factors that are impacting it. But yeah, women take longer.
Do you think with neurodivergence as well, because there's already a high statistical likelihood of having dysautonomia and things like that, it increases that?
That's exactly why they have increased on recovery, because of that pre-existing dysautonomia. And same thing, high levels of anxiety. They're already more heightened. They're more likely to report high symptoms or be experiencing high symptoms.
And you probably mentioned like your hypermobility disorders.
No,
as
she
well.
hasn't been
No,
With crossover symptoms and
It just keeps.
it keeps broadening. So that's where that multidisciplinary team approach comes in, and you look at the whole person. Don't just look, okay, they've got a concussion. Look at everything that's going on with them. Don't narrow them into one kind of symptom box.
And what were you going to say about hypermobility?
Oh, just the crossover symptoms. So we're talking about the neurodivergence.
Not the propensity to
As in
concussion?
having.
Is there a...
There's
I don't think there's anything on it.
No.
I mean, I would say.
There's not enough on hypermobility.
Like cervical instability would be.
So
I would imagine they would be more inclined to progress to the post-concussion stage.
Yeah.
But I don't
agree.
know
seen any
if
data.
that's just,
It'd be, again, they have a lot of the pre-existing symptoms, which means they're probably going to report higher symptoms, which means they're probably going to take longer. And then they also have pre-existing inflammation, everything else going on. It just really layers up. So that's why it tends to be like your normal community dwellers rather than your athletes that take longer to recover, because they tend to have more going on, more comorbidities, they're less active, they've got more mental stress, etc. Whereas an athlete, all they want to do is get back on the field.
A singular focus. All right. Well, thank you very much. That was very informative, and we're very grateful that you've come tonight, despite the cyclone hitting. And thank you all for coming. And I believe that next month someone might be talking about looking after patients over the age of 80. So I'm trying to look at how we take them out of their comfort zone and out of their little routine, and how we completely disrupt it with an operation, and then we just send them back home again. So I'm just looking at trying to talk about that process and maybe how we can facilitate older patients having surgical intervention rather than just saying they're too old all the time. So that's what we're talking about next month.
Thank you.